Presentation. I'm going to introduce our next speaker. We have Dr. Anika Goodwin, who is the founder and CEO of EyemergencyMD, a telemedicine company. She's a board-certified ophthalmologist, an oculoplastic surgeon, an innovator, and an entrepreneur. She's a telemedicine thought leader and a vision advocate. She received her bachelor's degree in pharmacy from the University of Chapel Hill in North Carolina, her MD degree from the University of South Carolina in 2001, did her residency at State University of New York Downstate, which she completed in 2005, and her fellowship in oculoplastics at the Kresge Eye Institute in 2006. We're very excited to hear Dr. Goodwin's presentation. She's innovating in the space of telemedicine, which is part of the front edge of how the healthcare landscape is changing in terms of how we provide access to care. Without further ado, please welcome Dr. Anika Goodwin.
Good morning. Thanks so much for being here so early in the morning, particularly if you're not a West Coast person and your timing is off like mine is. It's a pleasure to be here this morning. Let's get going. So I won't make you raise your hands because I do not want you to show your age, but there should be a few of us in here who recall when a Mac computer looked like that. Yes, yes, yes. And now we're here, towerless and everything. And some of you will remember when we couldn't just press the Safari button on our phone. We actually had to have one of these things. The young people may not even recognize that. With the cord that came from the wall into the back and the little line that kept going and going, especially at busy times as we were waiting to connect to the internet. Some of you will remember when surgery was lights, gloves, and instruments. Some of you know this to be surgery on the right. Know surgery as the surgeon sitting, not even touching the patient, and doing a procedure. This is where we're going. This is where we are. Lastly, some of you remember when medicine was only a stethoscope on a chest or on a back, and the only way to treat and diagnose a patient was to physically touch them and to hear and see things on your own. But we are now in a place where we can see a physician from our smartphone, from our laptop, from our tablet, without the physician being there physically to touch the patient or even in the same state as that patient. We enter the era of telemedicine. And so what is telemedicine? Telemedicine is the use of digital information and communication technologies to connect patients and providers, granting remote access to healthcare services to deliver and manage healthcare. Most of you who are physicians have done a residency. Telemedicine is not new. If you have done a residency or you have worked with residents, you will remember those midnight phone calls from your resident, from your first-year resident, wondering, is this what I'm looking at? I'm not sure what this is. And then we got even better, and we got smartphones and pictures, and they could send you a picture of it. Remember those times? Telemedicine is not a new concept. We've been doing it for quite some time. Yet in ophthalmology, we haven't been completely comfortable transitioning from treating patients hands-on within the four walls of our lane to doing it more remotely. So there are three types of telemedicine that we will discuss today. There's the synchronous type, which is what my company specifically offers and what I will dive more into today. There's the asynchronous type, which we are all very familiar with. It is not a coincidence that almost everything on this program is about diabetes and asynchronous telemedicine. And lastly, we'll touch on telemonitoring or remote patient monitoring, which will have significance in our specialty due to glaucoma. No longer will patients only have to come to our office to have their intraocular pressures measured. Our patients will be able to get this data at home, send it to us for interpretation, evaluation, and diagnostic manipulation. So let's talk about the one we're most familiar with, that you're going to hear a lot about today, the asynchronous method, which simply involves usually a rural hospital or clinic that just does not have access to our specialty or to someone who is able to interpret images for them. They're able to then take the images, whether we're talking about diabetic retinopathy or retinopathy of prematurity, which we won't hear much about today, but is definitely a huge use case for us in asynchronous telemedicine within ophthalmology. Those photos are then sent to the appropriate specialists to be evaluated, interpreted, and the treatment plan made and sent back to the originating hospital. We're very familiar with that. We're very comfortable with that. Our comfort level with that is what has allowed us to go into AI. That has allowed us to have the confidence to believe that deep learning is possible in these areas. Home IOP monitoring. How many glaucoma specialists do we have in our audience today? Are any of you using home monitoring for your patients at this point? No? So right here on the left, we have the eye care tonometer, and they make a version that patients are able to utilize at home to take pressures. And in the center, we have a contact lens that will do continuous pressure monitoring. It's by a company called Triggerfish. These aren't things that are commonplace and everyday for right now in our offices, but you will soon have patients, if you don't already, coming to you asking you about this technology. So soon, Goldman applanation will not be the only way for us to keep our patients' pressures in check.
What's the name of the contact lens brand?
It's by Triggerfish. Triggerfish. So let's talk a little bit about synchronous and the benefits of synchronous telehealth. Our colleagues outside of ophthalmology, namely internal medicine, psychiatry, things like dermatology, even ENT, ear, nose, and throat colleagues are enjoying these benefits of telemedicine, which include, I'm sorry, I can't see my screen, you guys, which include improved access, improved quality of care, convenience for the patients, and more timely care. Are these things that we could benefit from, our patients in ophthalmology could benefit from? I'd say it would be a resounding yes. What's keeping us from delving into synchronous telemedicine then? I think we're tethered. We're tethered to the very things that have made us a forward-thinking, progressive specialty. The things that have made people outside of our specialty look at us and say, that's cutting edge. Go into ophthalmology if you really want to be on the forefront. These things are our phoropters and our retinal cameras, our slit lamps, our OCT machines, and our tonometers. These things have tethered us to believe that ophthalmology can only be administered within the four walls of our lanes. I will tell you that that is not the case, and our colleagues in optometry have figured that out.
You've had a long, hectic day. You arrive for your eye appointment 10 minutes late to find that the doctor is gone for the day. And rescheduling is difficult because the times you can make it don't line up with the doctor's availability. None of this has to happen ever again. With digital optometrics, a doctor is available anytime that works for you. It's simple. When you visit a digital optometrics participating optical provider for your exam, you're given a digital tablet to record your basic information, as well as your ocular and medical health history. That information is stored on a secure server for the doctor's review. Then, an ophthalmic technician will bring you to the pre-testing area. Information about your current prescription will be recorded, along with corneal measurements and the results of an eye pressure test. Photos and videos can be taken, and additional testing can be done if necessary. Next, the technician takes you to the optical exam room. You'll look through the phoropter for a reading, and you'll see both an eye chart and a large screen, where a remote ophthalmic technician will appear. This technician will communicate with you through high-definition video conferencing and remotely control the phoropter and determine the right prescription. Now, you'll see the doctor. The remote technician signs off, and the doctor appears on screen, ready to communicate in real time. The doctor will also have full control of the phoropter to refine the preliminary prescription data if needed. They'll have access to your information, so asking questions and getting recommendations is easy and natural. Finally, your prescription will print, and you'll be ready to browse for the latest designs in frames and lenses. Your optical provider respects your time. They've invested in digital optometrics teleoptometry to provide you with a high-quality, comprehensive eye examination and an accurate prescription in less than 30 minutes, whether a doctor can be in the office or not. Ask your optical provider if they belong to Digital Optometrics Network and use the latest teleoptometry technology today.
Patients can go into an optical shop or an optometrist office, a JCPenney, a Sears, any of those places that have an optical shop. It does not have to have a doctor present there. They have trained a technician to be able to check visual acuity, to check eye pressure, to even do visual fields, to do every aspect of the exam, to take fundus photos, external photos of the eye, and video slit lamp examinations. Those things are then pushed through a platform to an ophthalmologist. Like I said, I do this sometimes myself. We're able to then look at all of the components of an exam that we would normally do ourselves or our technician would do in our office. We're able to make assessments, relevant diagnoses, and we're able to then give a prescription to the patient because they've been in a phoropter that is controlled remotely from someone in a different state. Give a prescription for glasses or contacts. If you're shaking your head in disbelief, then you're behind. Optometry is doing this right now. So let's look at some numbers. Less than 15% of preschool children get an eye exam. Less than 22% of children older get an eye screening exam. And of the estimated 61 million US adults who are at increased risk of vision loss, only 50% of those have visited an eye physician in the last 12 months. 50%. 90% of vision loss is due to diabetes, that is due to diabetes is preventable. That is all data from the CDC. 4.2 million Americans, 40 or over, suffer with uncorrectable vision impairment. And out of that, 1 million are blind. That number is expected to double by the year 2050. The annual economic impact of irreversible vision loss, $145 billion, with a B, dollars annually. 70% of people surveyed considered the loss of their eyesight would have the biggest impact on their day-to-day activities. So people understand the value of their vision. These numbers show that they simply don't prioritize it. I see headlines constantly in the news about other specialties and the successes and the use cases that they have discovered using telemedicine. I see teledermatology, I see the military, I see telestroke. Radiology has long been an example, and yet it seems that ophthalmology is missing from all of these headlines. It's not because the data is not there. We have data to show that telemedicine in ophthalmology works. The TECS study by April Ma out of the Atlanta VA showed very nicely that during a 13-month study that was conducted at 5 primary care clinics, not even within an ophthalmologist clinic. They used about 120 square feet of space to put the relevant equipment and a trained technician in. And in that study, they helped find vision-threatening diseases in 1 in 3 patients using simply visual acuity, refraction, intraocular pressure measurement, pachymetry, a pupil exam, and fundus photos. Patients loved the experience. They appreciated the fact that they did not have to travel to the larger VA clinic for their eye exams. The spectacle remake rate was very low in these, less than 1%, and the follow-up show rate for those patients who were identified to have pathology exceeded that of the diabetic teleretinal program that the Veterans Administration already offered. All of the diagnoses that were found in these patients, greater than 90% agreement, except for cataracts. We're not surprised about that, because if I ask 5 people in this room to all grade a cataract, we probably have 5 different answers. So not alarming as far as results are concerned. There's another study also out of Atlanta, an academic tertiary care center, that looked at whether or not having a fundus camera in the ED would be of any help to emergency room doctors in making diagnoses in patients. It did not even look at patients who have eye issues. It looked at patients who had neurologic issues that they presented with to look to see if those patients had hidden eye pathology that was either not suspected or not picked up. So the 350 patients who presented to the ED with headaches, focal neurologic deficits, some visual changes, or diastolic blood pressure greater than 120. It used a non-stereo, non-mydriatic fundus camera, and these photos were taken by nurse practitioners. The control read was by 2 neuro-ophthalmologists on all of the images, and there were 1,700 images taken over 230 nurse practitioner shifts. 83% of the people photographed had at least one eye with a high-quality photo. Only 3% had a photo that was of no diagnostic value. We can train mid-level providers to give us usable images in the emergency room and beyond. The mean photography session, and I think this is really significant, was 1.9 minutes. Not only can we train them to do it, we can train them to do it efficiently. The mean length of the ED visit was 7.5 hours. How many of your patients would love to bypass that if they could? We'll talk about some ways they can do that in a second. 48 of the 350 direct ophthalmoscopies done by ED physicians, 48 of those 350, only 48, had the back of their eyes looked at by the ER doc. I'm actually surprised it's that high, to be honest with you. More than 80% of findings potentially relevant to their acute reason for their visit were missed in those patients who had direct ophthalmoscopy by the ED docs. And then they were only found on the non-mydriatic photos. So we are missing pathology that is there because ER docs are not trained to be ophthalmologists. That is not their comfort zone. And it's important to note, as I said, this was in a tertiary care center. So this emergency department had 24/7, 365 access to an on-call ophthalmologist. And yet, we're still looking at this much pathology that was missed. My company, EyemergencyMD, offers an alternative to simply having ophthalmologists on call who aren't being called. It offers the emergency room an option of having equipment installed, having mid-level providers, or even lower-level emergency room staff trained to utilize basic robotic fundus cameras and basic slit lamp cameras that will take video in order to guide a patient through an examination that will gather the necessary data so that an ophthalmologist here can interpret that data and then either have a remote visit directly with the patient to discuss findings, send the treatment plan of care directly to the hospital's EHR, or consult with the patient and the facilitator there, the nurse practitioner, PA, whomever, to discuss next level care that the patient may require. All without anyone getting called out of their bed or going into the emergency room for something they felt like they should never have to go in for. So I don't want to tell you that telemedicine is a one thing that'll fix everything. It is not a magic wand. It's not something that will solve every problem that we have in ophthalmology. It can result in fragmented care because it's a lot more difficult to figure out when patients have been seen in telemedicine versus in real face-to-face visits because many EHRs don't communicate. It has a lot of variability currently in state laws and in payer reimbursement. There is not universal parity. And so navigating the waters of whether or not this is something that you can do in your state with certain insurers, will you get paid for it, is very difficult. So until we solve some of those problems and have more of a universal application of telemedicine, then many people will continue to want to take a hands-off approach. You have to have good internet connectivity. And in the rural areas, which is one of the places where this can have the most profound impact, they may not have that. And so we'll have to have our infrastructure strengthened in order to be able to offer this in some of the places that need it most. Image quality can vary from one place to another, but if we come up with algorithms to teach people to do this, which we have in retinopathy of prematurity and diabetic retinopathy, this hurdle can be surpassed. Equipment costs. Most of you are ophthalmologists, you understand what it costs to outfit our offices with the necessary equipment. And so this can be cost prohibitive, but hospitals aren't broke. And so when looking at the data of the pathology that we're missing that we could catch, then it's a worthwhile investment. Disruption is defined as something facilitated by technology and by inventors taking a fresh look at new business models and professional concepts. They are often shaped by consumers' dramatically shifting interests and frustrations with the status quo. They are embraced by insiders who sense new potential, and they are often unwelcomed by legacy stakeholders. Disruption is here. We have built a specialty and a career on the status quo. But it's time now to open our minds and consider that we can extend care in a way that does not meet the traditional methods that we've all been taught. We are who our patients are depending on to change the narrative and to change the statistics that I showed you previously. So it's up to us to move forward and be ready to do that for them. So you can continue to stick your head in the sands, believing that the only way to practice is within the four walls of your lane, or you can embrace change. Because if not, optometry, who is looking in many states to increase their scope of practice, up to and including surgical privileges, is doing it. There are hospitals in Texas and in Florida where optometrists are looking to take primary call in the emergency room. If we continue to be stagnant, they will move forward and we will not be able to protect patients and give them the highest quality care that we can provide. So ocular telehealth is here. It's becoming mainstream in many other specialties, and our specialty cannot afford to stand still. There are barriers that exist, but personally, I am trying to work through some of those barriers, and I welcome my colleagues to help in that endeavor. We didn't always have diabetic retinopathy screening protocols. It was something we worked through because our patients needed it. This is no different today. I know we're set in our ways, and we love the way we've always done things, but there are new ways that are on the horizon, and we have to be willing to embrace. Patients have expectations, but they will follow our lead. So the more mainstream and normal we make this, the more comfortable our patients will be with it. So we're at a crossroads, and you have to choose which way you'll go. Will you choose good quality of life for yourself and your patients, excellent quality of care for the benefit of your patients who depend on us to save vision, cost and efficiency improvements in the way we currently render care? I invite you to take the road currently less traveled, but soon to be the one that'll change how we take care of our patients. Thank you. I'll take any questions.
Sorry, I went to the microphone. Thanks for talking to me. My question is, how do you deal with licenses, and are there any malpractice concerns? And everybody else, please come up to the mic for questions.
So with licensing, that is the most expensive hurdle to take care of. My company has taken the position that we will license our ophthalmologists in all 50 states because we don't want to have those barriers. We'd like to create a system where ophthalmologists kind of work shifts, like emergency room doctors, and then that takes care of it. But if you're not willing to do that, it will absolutely limit the sections of the United States you're able to cover based on licensure. And it can be an expensive process to get all of the licenses. And with malpractice insurance, it actually is cheaper because we're not doing any surgery. So malpractice is easy to acquire. Because telemedicine exists in so many other specialties, the malpractice insurers have already fallen in line.
Great work.
Thank you.
Sometimes if I'm counseling an obese patient that's like borderline developing diabetes, and I'll spend some extra time to counsel them about diet and exercise. Is something like that potentially missed when you're doing telemedicine?
So with the example that I gave you, the video that didn't play, when I'm seeing those patients, if I have a patient who gives me a past medical history that is significant for hypertension or diabetes, I have an opportunity at the end of reviewing all of the data to interact with that patient remotely. I have an opportunity to ask, how has your A1C been? When is the last time you saw your doctor? Those types of questions. So I don't feel that it limits what I can delve into beyond just the ophthalmology of it. I like to call it website manner. And so you just speak to the patient as if they're in front of you.
Excellent presentation.
Thank you.
I wanted to encourage you to keep going. And the reason I'm telling you that is because Dr. Flowers, who came to see me at Howard way back in the early 90s, we were doing telemedicine. He was doing similar, he's doing retinal scans in underserved communities at Drew and using telemedicine. And I thought at that point that was going to be a really leading edge, much like it did in radiology, etc.
Yes.
But you're absolutely right. I am puzzled why telemedicine hasn't taken off in ophthalmology as it should. I think it should have. And I think what you're doing is really good work. There are some serious barriers you're going to run into because I've been in this a long time. But I think that you just got to keep going because the adoption curve is coming. The problem with telemedicine right now is that the adoption rate is low.
Yes.
And it's in the workflow where all that lives. It's not in the technology. And everybody in telemedicine in previous years always talked about the technology. The technology is going to improve. The AI is going to be integrated.
Yes.
The robotics are coming. But the problem is the people. And you got to get that. You got to integrate into the system.
Yes.
Whether it's the primary care system, ambulatory system, or hospital system. And I think there are real ways to do that. So at some point, I want to encourage you just to keep going, but keep an eye on that. So that's really important.
Thank you.
Dr. Goodwin, thanks for an excellent presentation.
Thank you.
What do you see as an innovator, entrepreneur, physician, advocate? What do you see as the primary bottleneck? What's the main barrier to telemedicine taking off?
As I have spoken to people in emergency departments and hospitals, the main barrier right now is equipment cost. They believe that our equipment is so expensive, it will be an insurmountable thing to do in order to bring it in-house. But equipment has actually gotten a lot cheaper. When I look at models out of India, and they're able to equip an entire van to be a mobile screening unit and do it pretty inexpensively. And so the technology has caught up to a point that there are multiple options, which creates a situation where things become a lot more affordable. So once we're able to sit down and talk to people about equipment costs and how they could recoup that cost based on billing for specialist consults and things like that, then it becomes easier. But I think that's the primary thing we spend our time talking about as we're talking to people about the service. Any other questions?
Fine talk, Anika.
Thank you.
Lori Riggins from Alabama. Quick question. Can you walk me through, I guess, how much time you take and how much of a charge? Because there's two issues.
Yeah.
I mean, is your consult fee less than it would be in your office, or is it more?
So the way we do this, my company offers two arms. We offer a direct-to-consumer arm, and that is the arm that allows patients to circumvent urgent care visits or emergency department visits, 7.5 hours worth of an emergency department visit, and go directly through our app on their phone or their tablet to connect with an ophthalmologist. Now, that is strictly intended for people with very basic things. So corneal abrasions, allergic conjunctivitis, because we don't have access to equipment for that. But there's some diagnoses, as we talked about, when your resident called you on the phone, you couldn't see that patient. But based on the history and based on the exam findings, you had a likely diagnosis. So that is the same premise that the direct-to-consumer arm offers. And that one is $75 per visit, and no insurance is required. For hospitals, the way we do that is it's a $45 per visit charge to the hospital. The hospital then is able to do billing on behalf of our service and recoup their expenses plus that way.
What about potential liability issues if someone has like a red eye and maybe it's handled with
Absolutely, great question. So the way we've set up the service is if someone comes to us direct to consumer and they have an issue that we believe warrants a higher level of care, then we have a clinical care coordinator who that patient is then sent to, who calls their nearest emergency room that the patient would like to go to, has a conversation with one of the emergency room staff or docs and lets them know we're sending a patient over and this is our suspicion. So once again, the patient's getting a much higher level of care, even if it's not care from their home, because now the emergency room doctor has some idea of what might be going on from the point of view of a specialist.
$75, how much does the doctor get?
How much does the company keep the doctor get paid? The doctor gets paid, I think, $25 per visit. Company keeps 50. Thank you.
All right. Thank you so much, Dr. Goodwin, for such an excellent presentation. Clearly, this is an exciting topic as it's at the leading edge, and based on the number of questions, you can find Dr. Goodwin afterwards at the break.